Welcome to this Milestone Explainer. You have officially made it to part 100, and today we are celebrating your graduation into an absolute master of evaluation and management coding and compliance. We're synthesizing everything into one ultimate capstone masterclass, taking you from the core clinical frameworks all the way to advanced auditing and future-proofing your career in the AI era. Let's get right into it.
Here's our syllabus for this capstone journey. We're covering the EM framework evolution, end-to-end clinical cases, audit-proof documentation, revenue integrity rules, and finally, your career roadmap.
First up, the modern EMF framework evolution.
Now, you all know the American Medical Association totally transformed the fundamental rules back in 2023. They completely overhauled the CPT guidelines, and thank goodness they did. They stripped away all those outdated, burdensome requirements so we can finally focus on what truly matters: actual patient care and the cognitive effort required by the provider.
Think about the contrast here. In the old days, we were basically bean counters, right? Tallying up bullet points for history and physical exams just to justify a code level. Thankfully, those days are long gone. Today, while the history and exam are obviously still essential for clinical validity, your code level is driven exclusively by the complexity of medical decision-making or the total time spent on the date of the encounter. It's just a brilliant simplification.
And because of that overhaul, we saw a massive consolidation of codes across the entire landscape. Observation and inpatient merged into a single streamlined range from 99221 to 99239. We have our clear categorizations for the ED with 99281 to 99285 and the office outpatient codes. But what's really cool is how this unified logic stretches seamlessly out to nursing facilities, home residence codes, critical care, and all the care management services. You literally no longer have to juggle fragmented code sets.
Section 2, End-to-End Clinical Case Studies. Let's see this in action.
Imagine our first scenario. A patient presents to the ED with acute respiratory failure. Because this is life-threatening and requires 75 minutes on BiPAP, we capture that intensity with critical care code 99291, or potentially an ED level 99285 depending on the exact timeline. When they're admitted, we use initial hospital care 99223. But the story doesn't end there. We track them through daily inpatient care with 99232, their discharge with 99239, and then, crucially, we capture their post-discharge transition back to the community with Transitional Care Management Code 99496. It's a complete journey.
Okay, here's a chronic care hub scenario. An established patient comes in for uncontrolled type 2 diabetes with neuropathy. That's a solid 99214 office visit. But to capture the full longitudinal complexity, we're going to add on the office visit complexity code, HCPCS G2211, and the social determinants of health risk assessment, G0136. From there, they are enrolled in remote patient monitoring. By tracking their device setup and monthly data transmission, we capture 99453 and 99454, plus the time-based treatment management codes 99457 and 99458 for the 40 minutes of review.
Now, navigating NCCI audits requires absolute vigilance, especially for same-day multi-services. Let's look at a complex one. Say a patient comes in for a periodic preventative visit, code 99396, but they are also experiencing a severe knee osteoarthritic flare that requires a same-day diagnostic arthrocentesis. You'd report the preventive code, a separate 99214 with modifier 25 for the significant separately identifiable problem, and the joint procedure code. Navigating these PTP edits and selecting the right modifiers all comes down to distinct, rock-solid documentation. That is your only shield against an audit.
Which brings us perfectly to Section 3, the golden rules of audit-proof EM documentation.
CMS defines medical necessity as the overarching criterion for payment. It is the absolute supremacy rule of coding. You could literally have 3 pages of beautiful templates filled out, but if the patient's diagnosis and the clinical plan do not justify a high-level E&M code, you must downcode for compliance. The documentation intensity has to match the clinical intensity, period.
So these 5 non-negotiable pillars form the absolute foundation of your audit survival. Beyond medical necessity supremacy, you have to clearly align whether you are coding based on time or medical decision-making. You must ruthlessly eliminate note bloat and cloning. You need explicit documentation of patient risk. Seriously, don't make the coder guess if a medication change is high risk. And finally, your ICD-10-CM diagnostic specificity must link logically to the CPT code. And yes, that includes meticulously tracking your social determinants of health with Z-codes.
Let's look at a real-world comparison. The dreaded EHR copy-paste clone.
Seeing all systems reviewed and negative copy-pasted across 10 different visits is a massive red flag. It literally makes auditors salivate. Contrast that with an audit-proof note. Reviewed prior EKG and compared with today's results, no change. Management plan discussed with cardiology. See the difference? It clearly shows individualized, patient-specific cognitive work. That's what payers want to see.
Section 4. Revenue Cycle Integrity and Compliance. Master Rules. Let's protect that revenue.
To mitigate the heavy risks associated with OIG work plan priorities and the False Claims Act, your compliance targets need to be sky-high. Utilizing tools like RATstats for statistically valid sampling, you should be aiming for a 98% quality assurance pass rate. And as computer-assisted coding and AI become the norm, you need a 95% AI confidence accuracy post-human review. But the most critical metric? A 100% human validation rate of those AI suggestions. At the end of the day, accountability always rests with the human coder.
Playing offense with your revenue means proactive denial mitigation. You need to understand root causes before they happen. For example, a CO97 denial usually means an invalid modifier or missing coverage, like forgetting that modifier 25 on a same-day procedure we talked about earlier. A CO50 denial flags a medical necessity mismatch, meaning your ICD-10 diagnosis linkage failed to support the EM level you billed. Master these denial codes, proactively fix these linkage failures, and you will maintain that elite 95% first-pass clean claim rate.
And now, Section 5, our grand finale, your career roadmap and final class graduation.
You've mastered the clinical, coding, and compliance frameworks. Now it's time to leverage organizations like the AAPC and AHIMA. Achieving advanced certifications like your CPC, the CPMA for auditing, or the CEMC specialty credential elevates you from a standard coder to an elite compliance auditor. You aren't just processing claims anymore. You are a vital clinical partner safeguarding the entire financial health of the practice.
The future of this industry absolutely belongs to the human in the loop. The emerging career trends for top-tier coders involve validating complex AI systems, transitioning into clinical documentation improvement, or CDI programs to teach providers how to write better notes, and running QA audits. AI is not going to replace elite coders. It's simply going to replace coders who don't know how to use AI.
I love this quote from the core principles of accountability because it beautifully summarizes your profound responsibility. Every coding decision, manual or AI-assisted, must be traceable with clear rationale, maintaining clinical integrity. Never compromise on ethics. Your signature on that claim is a promise of transparency and accuracy.
As we wrap up this 100th capstone, I want to leave you with this final thought. As AI completely changes the landscape of E&M coding, how will you leverage this masterclass knowledge to lead the next generation of healthcare auditing? You have the tools, you have the framework, and now you have the mastery. Go out there and elevate the standard of healthcare revenue cycle excellence. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.